Hi, everyone. It's Dr. Tofi. I am your hernia and laparoscopic surgery specialist. Welcome to HerniaTalk Live. Every Tuesday, you join me for HerniaTalk Tuesdays. Thank you for coming on Zoom. Many of you are here as a Facebook Live. Thanks for those of you that follow me on social media on Twitter and Instagram at HerniaDoc. As always, this session and all prior sessions can be found on my YouTube channel. If you miss them, you can kind of watch them later. But this will be an especially wonderful session because we have the greatly esteemed Dr. Ulrike Muschaweck. I have known and admired her since I got into hernia surgery in 2002. And of course, she's has a history much longer than mine and is world renowned for what she does. So I'm very, very honored to have her. She's in Munich, Germany now. So we did this a bit earlier than usual so that we can make sure that it's appropriate timing for her. So Dr. Muschaweck, thank you very much for joining us today.
It's a great honor for me. Thank you so much to invite me.
Thank you so much. So I was explaining earlier, we have this every week. I've been doing it since we started the pandemic, and our patients submit questions ahead of time. For your session, I have at least 25 questions, and we only have an hour to go through it. So we're not going to rush, but it's something I really look forward to. And those of you that are on, please submit your questions. We'll go through it. But while you do that, Dr. Muschaweck, if you can please give us a little bit of a brief, like how did you even get into hernia surgery? Everyone has their story.
It was by chance. I was the head of the outpatient department in the University Hospital of Munich. And then I got the, I was asked if I would like to do hernia surgery. And so this was 1988. And I went to the Shoulders Hospital in the beginning and to learn the Shoulders technique in Toronto. Yeah. And this was the beginning. It was the beginning and a big success from the first moment beginning then. So doing only hernia surgery, and I've been the first one in Germany to do only hernias, nothing else. So I have done more than 29,000 surgeries in the meantime.
Yes.
Hernia surgeries. And of course, as more as you do, as better you are. And as more as you do, as more experience you get. And this was the beginning of the development of my own technique, the beginning of the development of special techniques. So because of this, doing so many hernias every week and every day and learning about doing by yourself.
That's fascinating. You must really enjoy how much more popular hernia surgery has become because you're among the first to even do hernia surgery as a specialty.
Yes.
When I started in 2002, still there was a handful. There was like Dr. Amin. He was really the person that I looked up to.
Yes, I know him.
And he's in Los Angeles, so I got to know him and really admired kind of what he was doing to help promote the specialty. But now the residents really enjoy it. The medical students enjoy it. I feel like there's a lot more innovation with different technologies, and the residents actually want to do hernias now. I'm not sure they wanted to back like before, right? It didn't have the same pizzazz to it.
Yes, the same interest and the same, they didn't like to do hernias. Hernias have been something which nobody did want to do in the beginning. And so I was really the first one, and they looked at me if I would have become crazy, like this.
Sure.
But I started in 1988 and with my own hospital in 1993. And since then I'm doing this, only this. And this is a big interest now in all the patients, in the athletes, in the surgeon, in the worlds of the surgeons. It's really becoming a big interest. Has been becoming a big interest. Has been the beginning. They all thought I have become crazy, but I didn't.
Yeah, and very good. So most of your hernias are your specialty within the specialty, and then within that specialty is mostly groin pain due to missed hernias, groin pain due to complications from prior hernias and groin pain due to like a sports type injury in the
Yes.
groin. Is that fair to say?
Mm-hmm. You know, the beginning has been, I have done all the inguinal hernias, you know, small, big, all the types, recurrences, everything.
Yeah.
But within my patients, I got more and more athletes. And then I found out by myself that the regular hernia surgery for inguinal hernias is not the right therapy for athletes. So, and therefore I developed the special technique for them to do as less as possible, because this inguinal hernia is different to a sports hernia, which is the wrong name, but it's not like this. So this has been the beginning, and in 2002, 20 years ago, I developed this own technique, and it was first time published during the 100-year anniversary of Real Madrid in Madrid, you know, with the soccer Real Madrid, and since then it was a huge success. You know, since then all the athletes did want to become this technique, because after 14 days they are able to play soccer again without any problems. And so this has been a long way to find out about this, and now it's really, really common.
So one of the main things is trying to even understand what a patient has. So how do you differentiate someone having a sports hernia, which is not really a hernia, it's a sports injury, versus just a really small hernia that you can't see on examination?
It's really easy to let it sounds difficult, but it isn't. You know, you have to do the right diagnostic, and the diagnostic is to do the so-called dynamic ultrasound, and I do it always by myself. You have to ultrasound the posterior wall of the groin canal, and then under Valsalva you can see all the small changes. You can see everything, small hernias, no hernias. You can see the sports hernia. You can see everything, but you must do it correctly. And it is really, it's a short way to learn, but you have to learn this. I did learn it as well, but so I do it by myself. I ultrasound by myself. And see.
So you have ultrasound in your office?
Yes, always.
And you do it yourself?
Yes.
And I feel that that's great, because United States ultrasound is horrible. So it's not reliable at all. CT or MRI are much more reliable.
Yes.
I have one radiologist that loves hernias, and he does ultrasounds for me. I do some ultrasound in the office, but I'm not as good as you for like those little, like the groin area details. But I feel like radiologists need to learn more about
because
groin pathology.
Yeah, you have to do it under Valsalva, and really, it's really important to do it right. Otherwise, you won't see it. And therefore, because the MRI is always negative. Sometimes I get patients with 7 or 8 or 10 MRIs, you know, always negative. In the 1 minute, I see the ultrasound and I see the diagnosis. So
and what do you see? What do you specifically look for?
Yes, this is important to know about the anatomy. I will only say one sentence about this. The groin canal, the floor of the groin canal is a fascia, you know, and if the fascia is in a small area weak, if it is weak at some point, not the whole area, but some point, might be between 2 and 3 centimeters, then you see under Valsalva, you see a bulging, the typical bulging. And if it is bulging, you know, it is the cause for the problems, because this bulging is compressing a nerve, the genital branch nerve.
Correct.
And if you see this bulging, then you know he has a sports hernia, sportsman's groin, however you would call it. It's not a hernia because there is no intestine in this bulging, but preperitoneal fat of the layer behind. And this is the cause for the pain, because it's compressing a nerve.
Okay. So how do you differentiate a direct hernia, which is a weakness as well, from a sports type injury of the inguinal floor?
Because the direct hernia always is containing intestine, and you can see intestine in the ultrasound.
I see. Okay.
You know, as soon as you see intestine, it's a hernia, a direct hernia in the groin canal. But if you don't see intestine, only preperitoneal fat, then you know it's a bulging, only pushing the nerve forward during doing coughing, laughing, kicking the ball, whatever, then you know it's a sportsman's groin, sports hernia, athletic pubalgia, you know, all the same name.
Could it just be a small hernia where it's so small, it's the initial stage where just preperitoneal fat is there and no
Yeah,
intestine?
yeah, it can be, but it wouldn't make a difference in the therapy. If
Oh,
there's a
okay.
small hernia within this area, there is no difference in the type of surgery.
Okay, and then you mentioned your repair, which has become very popular for athletes. I believe that's your minimal repair technique. Can you explain how
Yes.
it's different than typical tissue repair, like Scholdice, Bassini?
Mhm. You know, shoulders is a very good technique, but
Yeah.
more for bigger hernias,
Mhm.
not for the small defects. If you imagine that the groin canal is 6 to 7 centimeters, the whole length, and
Mhm.
the defect in a sportsman's groin case is around between 2 and 2.5 centimeters. So I thought in the time when I developed this, why should I open the whole canal for the shoulder as technique to
Yes.
repair this small defect, to destroy the whole fascia, only to do
Yes.
the shoulder as technique? And so I
100%.
always, yes, I don't open more than the defect, which you can see in the ultrasound. I
Mhm.
prepare a special fascia flap in the area of the iliopubic tract.
Okay.
So you can do the first line without any tension, and then you can do an overlapping fascia surgery. And after 2 weeks, they are back on the field because there is no tension on this repair. There is no defect in the area of the sound tissue. You only do repair the small defect, 2 to 3 centimeters, not more. That is
So
amazing.
yeah, I also feel very kind of, especially I see a lot of women, and women tend to have small hernias. And
Yes.
so a Scholdice, it's so appropriate for your typical male hernia because it's usually larger hernias, and it makes sense to open up a defect a little bit more, right? For the whole floor. But if your defect is so small, I feel it's wrong to completely open up the pelvic
Yes.
floor, the inguinal floor to address it. So the Marcy repair is a simple closure. How is your repair different than a Marcy repair?
It's not a simple closure. You have to prepare a special fascia flap to do this. It is closing tension free. That means that you do a overlapping of the fascia in the area of the defect tension free. Therefore, I prepare in the distal area a special flap of fascia of the pubic tract, and then I overlap the transverse fascia to close the defect, still without enlarging the defect. You know, it's
Yeah,
really important not to enlarge,
yeah.
to do it tension free. And then you can close the canal without any problem. And the recurrency is close to zero because you don't open sound tissue.
What do you think about just the diagnosis of sports hernia? Do you think it's overdiagnosed or underdiagnosed? Hold on, there's my,
You mean on the questions about the nerve?
no, sorry, this one. Do you feel sports hernias are overdiagnosed or underdiagnosed? I feel in my town, if people come and they don't have a bulge,
Mhm,
and they have pain, hernia pain, they're
mhm,
like, oh, you have a sports hernia, but they don't. They actually have a typical indirect or direct inguinal hernia. It's just so small.
mhm.
It's not a sports injury or tear. And I treat them as a hernia, but I feel that some people, they just call it all sports hernia. What do you think? Do you think we're over-diagnosing or under-diagnosing?
Overtreated. I think they
Over-treated.
overtreated. Yes, because a sports hernia doesn't need any mesh. Sorry to say this, because I know you use meshes.
Yeah.
They don't use any mesh. They don't use to enlarge the defect. They only need the repair of the defect, and you can measure the defect with the ultrasound. If you do it properly, you can measure the whole defect and you see it's a small defect. Why should you open the whole canal? Why should you do more as necessary for a sports hernia? You know, a real hernia needs more. A real hernia. The real inguinal hernia needs more, but this doesn't need any more. You know, it's important not to do more, not to destroy anything. And this is so much overtreated, all over the world.
And then do you feel that because the nerve is being pushed, that they get nerve pain, right? Many people, they don't have the bulge, right? But they have nerve pain, especially women. I see they have pain into their vagina, into the inner thigh, clearly neuropathic. Do you then, what do you do with the nerve? How do you decide in a true sports hernia whether you should touch the nerve, or do you just fix the hernia and then the nerve pain goes away?
No, so it's an easy decision, because I always see all the three nerves in the groin canal, and one who is responsible for the groin pain because of a sports hernia is a genital branch of the genitofemoral nerve, and you can see this nerve immediately if you know how to look or where to look for. And if a nerve is sound and without any damage, then a nerve is shiny with a shiny surface. If it's damaged, it's thicker and it's sometimes like a pearl chain. It's not so. Therefore, you can immediately see if there is a nerve damage or not. If there is a nerve damage, you have to remove the piece of nerve damage. Otherwise, you keep the pain forever. And this is only if you touch the skin. It's only a sensitive skin nerve. If you touch the skin for the next weeks after surgery, there can be, must not be, a bit of numbness for some weeks, which will disappear because it's only a piece of the damaged nerve. Only a piece, not the whole nerve.
Do you think if you don't touch the nerve and you just remove the hernia, you address the hernia from pushing on it, that the body will just heal that nerve?
No. If a nerve is damaged and not shiny any longer, it will never recover.
Got it. And then since you also treat a lot of groin pain, chronic pain, what are your thoughts on selective neurectomy versus triple neurectomy?
You know, the triple neurectomy is, in my opinion, a very terrible therapy.
Too much, don't you think?
Yes, much too much. I have done this. It's much too much, because there are only sometimes two nerves, if so, but mostly only one nerve which is damaged. Three nerves, all the three together, it's much too much. I never would do it.
Yeah, so selective neurectomy. Yeah, I do the same. You know, there's this thought that I think Dr. Amit was really the head of it, where he was saying that nerves talk to each other, and so if you don't cut one, then you'll still have chronic pain. But my feeling is that's not really what's going on. If you always cut all three nerves, then you're never wrong in which nerve should have been cut. But if you're selective, then maybe you're wrong, and that's why you may be missing it. But I feel like
you cannot miss it. There is one trick. I tell you one trick.
Tell me.
You cannot miss it, because I developed this so-called intraoperative nerve response. If you, before surgery, mark the point of pain, and during surgery, find out this mark, because I don't do under general anesthesia, under local and sedation. The patient is for some minutes a bit more awake, and then you find immediately the point. You see the nerve. Why should you cut all the three nerves? I never would do it. You find immediately the point when you go with a sterile needle into the marked point, down to the nerve, down to the pain point. You ask the patient, is this a point of pain? And the patient is saying yes, and you know what it is. And you don't have to cut all the three nerves.
Yeah, I agree. I also prefer to do the mesh removals or any kind of groin surgery under IV sedation, not and local anesthesia, not general.
Because then you can find out, otherwise you wouldn't.
So one of the risks with touching nerves is you can instigate something called CRIPS or CRPS, complex regional pain syndrome. Have you seen that in
No,
patients?
no,
Okay.
no, not yet.
Yeah, it's kind of a, I'm always concerned, we looked at our data of neurectomies and what the outcome was. So in our data, it was a 4% risk of neuroma. And then we had 2 patients that, ended up with complex regional pain syndrome. And, it's unclear if it can be prevented, but it's a very difficult problem to treat if a patient kind of falls into that category.
Yeah, but I think it's also a question of how to cut in it, how to cut the nerve. If you tie a nerve or if you burn a nerve, you can wait for pain after neurectomy. I never would tie a nerve. I never would burn a nerve. This is only to take a knife,
Yeah.
shortcut, and it slips away. So I never seen a neuroma after cutting this nerve. If necessary, you only have to do it if necessary, because it's really, it's a bit for patients frightening to know, to think about a nerve which has to be removed. But they even don't feel it, because if you cut it right, the nerve is slipping back, and there is no tissue around, no damaged tissue around. So the possibility of developing a neuroma is depending on the tissue around, of scar tissue or whatever. But
Yeah.
if the nerve is slipping back into sound tissue, there is no risk of a neuroma.
Yeah, I feel some people just make neuromas. I've treated a couple where they keep getting neuroma over and over again.
Okay.
I don't know why. So you just sharp cut, and then you as proximal as possible,
Yes.
and then it gets buried into the muscle.
Yes.
What about if you get bleeding? Do you get, because there's little vessels there with the
Yes,
nerve
because I separate the vessels before I cut the nerve.
Okay.
I separate the vessels, and then it can be cut and is slipping back, and there is never a problem again.
Yeah. Let's talk about, let's see, here's a question about athletes versus non-athletes. So here's a question a patient submitted. Can a non-athlete who had a prior tissue repair, actually, let me ask you this. Can a non-athlete get an athletic pubalgia, or can a non-sports person get a sports hernia?
No.
Okay.
If you have been operated before, you only can get a recurrence. But if the sports hernia is only possible in a sound tissue without surgery before. But if there has been a surgery before, of course you can develop groin pain. Of course you can develop pubic pain because of recurrence. But it's called medial recurrence or something like this. But it's not as a primary sports hernia, athletic hernia. Not.
Got it.
We wouldn't
Okay.
call it this.
So this is a patient, I think let's just say he's 70 years old, 70. Can a non-athlete with a prior tissue repair of a direct inguinal hernia 40 years ago develop a sportsman's groin from extreme lifting accident?
No.
No, correct?
No, and the second, yes, you can differentiate, you can. So first part of the question is a clear no.
Yes.
Because after 40 years, two no's. You cannot get new hernia because of lifting. You get a hernia or a recurrence because of the tissue repair, which has perhaps not been really done absolutely perfectly. Then you can get a recurrence, but it's not a question of lifting or sportive activities. So that we never would call it like this. Athletic pubalgia is in combination with a sports hernia or sportsman's groin, because in the case of a sports hernia or sportsman's groin, the groin canal becomes wider. That means that the rectus abdominis muscle, is retracting to the medial side and is causing more tension at the pubic bone. And this is the cause for the pubic pain. So therefore, if there is a man who has been operated before and gets a direct recurrency, he can get, of course, pubic pain, but because of the
Yes.
recurrency and the therefore increasing tension at the pubic bone.
Yes. So, okay, same situation. Let's say this is the same patient. His chronic groin pain is from a recurrent inguinal hernia, which is expected. It's well, not unexpected 40 years after tissue repair to have a recurrence, especially for a direct, right? So what are your thoughts about a tissue-based inguinal hernia repair after you already have a recurrence from a prior tissue-based repair?
So in my opinion, you can do a second tissue repair as well. You can do it without using a mesh, but this is not a question of the technique. It's a question of the quality of the transverse fascia of the groin canal.
Yeah.
If this layer is with the scar tissue and is not good any longer and shiny with a shiny surface any longer, then you should not use a second tissue repair. This is only depending not on the size, not on the technique before. It's depending on the quality of the posterior wall of the groin canal.
And can you tell that before surgery?
Yes.
Okay.
I can, yes, but not for 100%. I can see in the ultrasound the thickness of the deepest layer, which is important for suturing, but the quality can only be seen during surgery, not before. So you cannot promise the patient before surgery that you can do a second suture repair. You have to see the tissue, you have to see the quality, if it is shiny. If the fascia is shiny with a good quality, then you can do a suture repair.
Okay. That's, yeah, I agree with that. It just seems, maybe I feel that if you tear a tissue repair, and I perform a lot of tissue repairs, but if you tear that, you're automatically dealing with less tissue to redo. And then the next repair will be even tighter than the first repair and more likely to give either recurrence or chronic pain. What do you think about that?
Always depending on the amount of sound fascia and always depending on the quality. This is the only question. If there is only a small rest, let me say a small rest of a transverse fascia after previous surgery, tissue repair, then you should not do a new one again. But it's not so very often, you always find that after a tissue repair, if there is recurrence developing, then you see that the quality, that the tissue repair has not been done properly because there is still a lot of sound fascia in the deepest floor, and then you can do it still without any mesh. It's depending on the amount of sound fascia. This is the whole question.
Here's an interesting story. This is a female. She says she's had chronic groin pain for several years. Historically, she was an endurance triathlete, but now she's completely sidelined and does not compete. She's seen multiple hernia specialists in the United States with mixed opinions and diagnoses. She was diagnosed by some with a small occult inguinal hernia based on MRI and dynamic ultrasound. Others say no, it's not a hernia, it's a sports hernia or athletic pubalgia with slight detachment of her rectus and her pubic bone. Her pain is in the groin triangle and upper thigh, but she also has pain about an inch below her belly button and straight down for another 3 inches. And this confuses all the doctors because now she's got this other pain up near her belly button. So do you ever see pain in the pain cephalad or above the hernia?
Not very often, but I have seen this.
Yeah, it happens.
Yeah, it's not very often. But sometimes it's kind of irritation of the inguinal nerve, which has some branches going upwards, and this is sometimes for the patients a feeling like having pain in the umbilicus area because of this nerve radiation,
Yeah.
Important is the type of pain. If there is some burning, for nerve pain, you always need burning,
Yeah.
electricity shocks, radiation, and not a special point, only one point of pain.
Mhm.
You need a field of radiation of the nerve, a field of radiation upwards or downwards into the inner thigh of the upper leg. All these typical areas, these are important to find out. And this lady perhaps has a irritation of the inguinal nerve because one of these branches is going upwards, and perhaps radiates more than in other cases. It's not very common, not very often, but I've seen this, yes.
Yeah, I always ask that question because sometimes I see people with inguinal hernias, but the pain shoots up towards their belly button.
Yes.
And I can't explain why that is, but I've heard it multiple times. Not a lot.
Yes,
You're
not
right. It's definitely not common, but yes. So here's a very complicated question only for you. Please describe what is the iliopubic tract and how you use it to create a second supporting layer for the transversalis fascia repair. And does the non-athlete need that second supportive layer? This is a patient, by the way, that sent this. So they're very informed, my viewers.
So iliopubic tract is the fascia which is continuing into the leg, going down and continuing in the leg, and it's ending, or it's going upwards into the groin canal and ending there with a small edge. When you find this edge, and you always can find it if you clarify the groin canal with preparating all these things, then you need this layer for a tension-free repair. Therefore, a non-athlete, of course, needs this supportive layer, because otherwise the repair would not be tension-free. There's no difference between a regular patient and an athlete. It's a type, or it's a part of the technique.
And when you do tissue-based repairs, do you kind of look at your hernias? Okay, it's a larger hernia, I'll do a shoulder. This is a smaller hernia. Do you change based on size and quality of the tissues?
Yes, of course.
Yeah.
I call it tailored approach, and of course I do the Lichtenstein repair, which I learned also with Parvis Amit in Los Angeles, who was a good friend of ours. So I've seen all the techniques in the original places, and of course, if necessary, I do this, and if necessary, I do a shoulders as well. But you have to make the decision between the different types of hernias. You cannot do the same technique for all the hernias. And this is the main point why a lot of hernia repairs are failing. Because you have to...
They do only one type. Yeah,
yes.
Agreed.
But they do all the same for everybody.
Everything.
And it cannot work.
I hate it.
Yes.
I hate it. What about women? Do you change your technique based on whether it's male or female?
No, because they have the same groin canal, they have the same tissue layers. I even more try to avoid to use a mesh in case of women. But of course, in case of a big hernia, big direct hernia with a complete weak tissue, of course I use the Lichtenstein technique. It's always depending on the findings, intraoperative findings.
Okay. Well, thank you for bringing up Lichtenstein, because there's a question about that. Dr. Amid, when he teaches the Lichtenstein, he says very important not to put a suture into the periosteum for that medial stitch over the pubic bone, because he feels they can cause osteitis and chronic pain. But, do you think that's true? Is that okay? But don't orthopedic surgeons put sutures in periosteum all the time?
Yes, unfortunately, yes.
Oh,
I never
okay.
do. He's completely right with the whole his whole opinion. Yes, I only can agree.
I feel like I do the same. I follow his directions, but if you think about it, orthopedic doctors are putting sutures for disruption. When you have a disruption of your rectus muscle or a tear for adductor, they're putting sutures full thickness into the periosteum. So why is it wrong for Lichtenstein?
Yes, so why should you do it? I don't know any cause for this.
No, I agree. We don't have to do it. I agree. But orthopedic doctors do it all the time. I just wonder if that's not the reason why people have chronic.
Orthopedic are no real, in my opinion, it's no real hernia surgeons, you know. They shouldn't do hernias. And to suture a perios means that you can get chronic pain, that you can get the infection and really chronic pain. And if you remove then the mesh, which I do 100 times a year, then this pain is consisting because the perios is damaged forever.
Yeah.
So I never would do it.
Question about pregnancy. Do you feel that any of the operations that you do, whether it's for inguinal hernia or a sportsman hernia, that pregnancy would put it at risk afterwards, or no?
No.
Yeah.
If you do a tension-free, never ever. You know, it's only a question, you know, the pregnancy, if you would do a hernia surgery and the lady would become pregnant afterwards, and you say, oh, if you become pregnant, you get a recurrence. it would really be terrible. Now, you have to do it tension-free still, and then you can become pregnant a lot of times, no problem.
Yeah. Okay. A lot of questions coming in. This is great. I'm trying to feel, I'm getting questions from Facebook and Zoom. They're all coming in, and then they're also coming in from what's been prepared. Oh, what are the typical symptoms? Let's go to before even surgery. What are the typical symptoms for diagnosing a sportsman hernia that's different than a typical inguinal hernia?
They are extremely typical. Typical pain is pain during moving, sneezing, coughing, sometimes burning, sometimes sending electric shocks, radiating into the inner thigh of the upper leg, sometimes to the testicle. So it's, if you hear this about these symptoms, then you nearly can say, okay, I don't have to ultrasound you, I know the diagnosis. And then you ultrasound and you see immediately the bulge. So it is absolutely typical for sportsman's groin, sports hernia, all these symptoms. They must not be all the same, you know, sometimes only radiating to the inner thigh, sometimes only radiating to the testicle, but all together they are typical for a sports hernia.
But aren't those also typical for inguinal hernia?
Sometimes yes, but not, you know, what is sometimes different is they don't have pain, inguinal hernia don't have pain in the, perhaps in the pubic bone area. Why not? Because the tissue is much weaker and the hernia is going through the tissue downwards in the direction to the testicle. And there is no pubic bone any longer. You know, the sportsman's groin is getting a wider canal without developing a hernia and therefore causing tension at the pubic bone because of the rectus muscle. And that such around this area around is weak, is not weak but strong. Therefore, the tension is increasing, and this is the main difference. You know, because because the rectus muscle is in the area of the strong fascia, and not in case of a hernia around, surrounded by weak tissue and the hernia sac which is going down and avoiding tension at the pubic bone.
So a sports injury often is not surgical. So how do you determine when it's a surgical problem or when just physical therapy and rest and injections and anti-inflammatories can help?
So there is a frame of 6 to 8 weeks of conservative treatment in case of a sports hernia. And if this doesn't work, you have to change to the surgical technique, because then you waste time. So 6 weeks, 6 to 8 weeks is the frame for us.
6 to 8 weeks. Okay, very good. Next question. Let me reread this. Okay, so is there a role for mesh in treating? Let's say you have a disruption from a soccer player. Is there a role for mesh in treating sports hernias?
Never. never ever. You know, two causes. One is still that there's only a small defect, if it is really a sports hernia. But the second one is, if you use a mesh, then you lose a lot of elasticity of the abdominal wall layers.
Yes, you do. Yeah,
You know,
that's
if you
true.
have a mesh between these layers, you
Yeah,
get a kind of stiffness. And this is not good for an athlete. He needs his elasticity, his full, the free movement of the layers to do all the sports types which he wants to do. So never ever a mesh for athletes.
yeah. What about, you know what, let me push you on that a little bit. What about laparoscopic repair? That's less of a,
You know,
doesn't limit the athlete as much than an open mesh-based repair. What about laparoscopic repair with mesh?
why should you put a mesh size to 10 to 20 centimeters, something like this, 9 to 15, 10 to 15,
Yeah,
to the groin canal because of a 2 centimeter defect? I never would understand this. You know, why? It's not it's a question of the finding. And why should you treat a 2 centimeter, a midget, 2 centimeter, a defect with a big mesh? There is no sense for me at all.
yeah,
You know, you can do it properly, you can do it perfect. I know you do it perfect. I know everything, but not for an athlete. Why?
yeah,
You want a mesh if you only have a sports con, I think you never would want to get one. You know, there is always the risk of mesh migrating, mesh shrinkage, mesh pain. This is still not 0%. And
what do
why
you,
should you?
yeah, so the European Union, the European Commission has already changed the market for meshes. It's considered a high risk device, and you're not allowed to actually sell mesh unless there's human testing that's been tracked. So that's completely changed. We have not done that yet in the United States. There's talk about it, but in the United States for hernia mesh, it's still the same.
Yeah.
What have you seen in your practice or your colleagues' practices that has changed in the past year since this new kind of restriction on meshes for
Yes,
hernias?
I didn't see any change. They only see that more and more doctors are using mesh um, for all the cases, sports, hernias, everything. Without, I think it's a question how to do the diagnosis and how to know what you want to die, what you would have to see with the diagnosis, with the diagnostics you can do. If you understand the anatomy, if you see the small defect, I think they would really change their technique. They would not do it, but nobody is doing the dynamic ultrasound. Nobody, only
Yeah,
two in Munich, I don't know. And if you go in other cities, nobody is doing this. And if so, they do it only and don't see anything. You know, it's you have to see what you have to find. You have to look especially for this. And still, I don't see any sense for a mesh in case of an athlete or in case of a small hernia or in case of a young man with a sound tissue. This is, for me, still no need.
do you think that the standard should be changed so as much as possible, sometimes we can't do a good tissue-based repair, put those
Yes,
aside, but
yes,
if
there's
a tissue repair can be performed, do you
yes.
think our teaching should change and we should say do a tissue repair first? If all is well, great. If it recurs, then use mesh. What do you think about that?
You know, I think the problem is that these tissue repair surgeries are not really shown in the hospitals. They don't learn it. You know, the surgeons don't learn it properly. They
Yeah.
learn by a surgeon who is saying, "Oh, let us do a mesh. It's much faster. Let us do this or this." The surgical technique with the suture repair is demanding. If you don't do it tension-free, then you get a recurrence. If you don't do it right, you also get a recurrence. So they are afraid about of this. And then the second point is that they are talking about chronic pain. I
Yeah.
can tell you, I don't have not even one patient with chronic pain. So this is a question how to handle the nerves.
You
How
haven't had any patient with chronic pain? I want to give you a
yes.
prize.
Really, I don't have not even one. I did do a lot of surgeries with
Yeah,
patients with chronic pain after mesh repairs, with mesh removals. But in my patients, I don't have one patient. This is true. I have, of course, recurrences,
yeah.
0.2%, but not one patient with chronic pain.
And okay, in that 0.2% of your recurrences, how do you treat them?
Then they get a Lichtenstein repair. Because I have done then the suture repair with using the whole fascia, but it's only 0.2. It's not too much. It's if one would say I have 0%, I think he would lie. There's no surgeon in the world with 0%.
Yeah,
But then I do the Lichtenstein repair, and it's fine then, and there's no problem.
okay. Question for you. What are the outcomes for surgical treatment for ALD? I guess we kind of discussed that. So the expectation is if you have a tissue-based repair for sports hernia, it sounds to me that any early hernia too, that's not big, no intestines involved, you would also consider that a sports hernia. Does that sound right?
I didn't get the first part of the question. What is it
Um,
with the
so the
small?
Yeah, so if it's a small hernia, no obvious bulging, you do an ultrasound, you just see fat there, but it's a direct type hernia, let's say, or even indirect with a small lipoma.
Mm-hmm.
Um, would you call that a sports hernia because it's not like there's no intestine involved, no hernia sac?
I would only call it sports hernia if it would be in the medial part of the groin canal with the bulging of the posterior wall.
Okay,
Then
so like a direct type
yes, and other
situation.
ones would be indirect hernia or
Yeah,
direct hernia, but not a sports hernia.
okay. And then the expectation is that they don't tear again. Low risk of that because that's part of the chronic pain after tissue repairs is it's too tight and they're constantly in the state of trying to tear through the sutures, right?
If you do it don't do it tension free, of course you can get a feeling of tension. This should be avoided. It should be avoided.
Mhm.
And also, it's not only a question of tension, it's also
Yeah,
a question of how to handle the nerves, to be honest. Really.
yes.
If
Well,
you put,
anatomy, right?
yes,
Anatomy.
yes,
You have to know your anatomy. Yeah, I think, when I teach my residents tissue repair, they do McVeigh, Bassini, Marcy, Scholdice, Nihus. I do posterior sometimes as needed.
yes,
So they love it, and mostly it's because they get to see anatomy, and it's
yes,
so important to understand the anatomy, and they love it because
yes,
you're more involved in the repair than
absolutely.
your typical mesh-based repair. Yeah, I agree with that. Um, these are so many questions. I love it. Let's see. Can a sports hernia and other groin injuries recur like a true hernia would?
You know, so far I don't have a recurrency, but of course it can develop. There is a risk of 0.1%. The risk never is zero, but most of the problems after the sports hernia surgery is the adductor pain because they have had pain before because of the compression of the genital branch nerve, which is causing pain in the groin and inner thigh. So they need for sometimes a longer treatment of the adductors. And this is for the patients if they would have a recurrency, but they have still adductor pain because of the rest of the nerve compression. So this is the combination of adductor pain and groin pain because this nerve, if compressed, is sending the pain downwards. But a real recurrency, I never have seen, no. Because
Yeah.
I don't open sound tissue. It's the main cause. I don't cut sound tissue. This is the secret.
Yeah, I have an issue with that too. I agree. So you're familiar with Dr. Bill Myers. We've had his associates on this show before. Um,
Yes.
how, what are your thoughts on his types of repairs for rectus, adductors, uh, fascia tears, et cetera?
I would love no comment.
Okay. You know, there's so many different, well-known, there's a handful of, I would say maybe 4 or 5 in the world that are very well known in sports hernia repairs, and they all have a different technique.
Yes,
You
they
know, it's
cut too
so
much.
interesting to me.
Yes, I know. So I'm not. I don't love this kind of technique, and I know him personally, and I don't want to say anything about this.
Yeah. We also talked about the Lloyd's repair, or sorry,
Yes,
Lloyd's release. What do you,
yes,
if you can explain what that is and
yes.
what are
So
your
the
thoughts
lordship
on that?
is, in my opinion, is terrible because he's doing this laparoscopically, but this is not the point. He is cutting the inguinal ligament because, in his opinion, the ilioinguinal ligament is causing tension. So to cut the groin ligament means to cut one of the most important structures of the groin canal,
Yeah.
which you need for any repair. And if you cut it, you can get so much different pain afterwards. So no, it's not my favorite.
Yeah. We haven't discussed mesh removal. It's a lot of what you do. You don't put in too much mesh, but I'm sure you remove more mesh than you put in.
Yes.
So tell me a little bit about how you do it. You go, it's done outpatient, correct? Or do they stay in the hospital?
No, you mean it's mesh repair or the
Mesh
mesh
removal.
removal?
Yeah,
Mesh
mesh
removal,
removal.
they should stay for one night. I do
One
mesh
night.
removals nearly 4 times a week, mesh removals. And they stay for one night because they get a drainage for one night.
Mm-hmm.
And then, but they can walk around the same day. They can walk around immediately. The beginning of training is the same fast and short time as without removing a mesh, because you
Mm-hmm.
have to do it very carefully, not destroying the whole internal oblique muscle. But to find out immediately about the pain cause, that means a damaged nerve, and then to do a mesh-free repair. So this is the whole secret. So one night because of drainage and possible pain treatment if necessary.
Mm-hmm. And how often do you have to cut a nerve with mesh removal?
You know, the mesh removals after the Lichtenstein repair, we are talking about these mesh removals. The
Yeah.
nerve,
Maybe Periosteum hernia system or plug sometimes.
everything,
Yeah, but
everything.
not laparoscopic mesh removal, right? I mean
No, no. And I don't do this because then
yeah,
it's much more difficult. You have to
yeah,
do a laparoscopy
that's
again.
good.
It is really
That's
difficult.
good. Yeah,
Yeah, but I do a lot of second surgery after laparoscopic repair because the nerves are involved because of the mesh behind. So
yes,
with chronic
yes,
pain, I don't
yes.
remove these meshes. So in case of an open mesh removal, the nerve, it is always the ilioinguinal nerve. And this is always a question of a wrong technique, in my opinion, because this mesh is directly sutured onto the nerve. And asking me if I remove the mesh, the nerve, you cannot separate the mesh
Yeah,
from the nerve any longer. The mesh and the nerve are one package, grown together. And after removal, they don't even have a lot of numbness. The pain immediately is disappearing. You have to
yeah.
follow.
I've
Yeah.
seen that. They're not numb and yet their pain is gone. I'm like,
Yes.
there are many people who have done neurectomies as part of the mesh removal. Like you said, the nerve and the mesh, it's like
Yes. It's
Velcro
one,
together.
one, one piece, one layer. Mhm.
I tell the patient, even if you don't have nerve pain, just the act of me removing the mesh will be injuring
Yes.
the nerve.
Yes.
So if that's the situation, I'm obliged to cut the nerve.
Yeah.
Okay, so you do the under sedation and local anesthesia, is that correct?
Yes. Yes.
And then
Correct.
one day stay.
Don't miss the main point of pain.
Yeah. And I love that you go all over the world actually to do these
Yeah.
operations. So what I struggle with would be the follow-up, because these are patients that need a lot of hand holding because their recovery
Yes.
is not typical. So how do you follow up when you've operated on someone in a different country?
So I always stay in this country for 1 week. and
Okay.
do these surgeries in the beginning of my stay. And then I have always a surgeon on the hospitals who are supporting me and taking care for the patients after this 1 week.
Yeah.
And there is a question we are mailing of sending pictures from the possible
Okay.
problems, but they are not. After 1 week, the main problem has gone, you know, if there is
Yeah.
a problem.
Yeah. What if you need someone to do like a nerve block or something? You
But
have like people to do that for you there?
yes, but it's not necessary very often. So
Yeah.
if so, of course, they would do it. Yes, yes,
We have a question. Okay, we have a question about recovery. We haven't talked about recovery. What is your post-surgical protocol for
mhm.
sports hernia or pubalgia and occult hernia repairs? And do you do physical therapy? What does that look like? And how long until these people are fully recovered?
So day of surgery is day 0. Beginning from day 2 after surgery, they can start with fast walking.
Yeah.
Day 5 or 6, they can start with jogging. Day 8 to 10, they can start with sprinting and whatever. And day 14, they can kick the ball and can go back to the field. And this is, you know, the only limit which I have in the days before is if they feel pain, they would perhaps do it 2 or 3 days later than day 2 or 3. But the main protocol is after day 2 or 3, fast walking, running, day 5, 6, or 7, depending on the pain, sprinting. So it's after, within 14 days, they are back to full recovery. 14
And
days.
then my last question for you is, what are your thoughts on mesh? There's a big movement. I call it anti-mesh movement. They're actually calling for mesh to be banned. They say it's a toxic substance, etc. As you know, there's certain operations we cannot do without mesh. Now, mesh means there's 1,000 different types of mesh. It can be
Yes.
biologic, absorbable, synthetic,
Yes.
polypropylene, polyester, PTFE, PVDF. There's mesh
And
can mean a lot of things, but not all hernias can be repaired with mesh. And oftentimes making the wrong decision of doing something tissue-based actually makes the situation even worse. So that's my thought. What's your thought on mesh? And what's your answer to people that say all mesh must be banned?
uh, it's difficult, you know.
Yeah.
I absolutely would not use some special type of meds, for example, plugs or this
Yes. Correct.
PHS or whatever. I never
Yeah.
would use it because imagine about the amount of mesh in the groin, about
Yes.
the loss of elasticity, about the feeling of foreign body. You know, this is you have to respect this before you put these meshes.
Yeah.
I don't want to say I never would use a mesh. I use meshes, you know, for big hernias and weak tissue. I use
Yeah.
meshes as well, but I don't use all these plugs and whatever and this with the frame and all this bath
Yeah.
hernia system and you know I don't use this. But if you use a mesh properly, it is a big help and it can remove the hernia forever, but you have to do it properly as well without stitching the pubic bone.
Yes, correct. Thank you. Yeah, I think it's the surgical technique is super important, your anatomy, and then tailoring, like what you said, pick and choose
Yes,
which patient gets what type of hernia repair. Even in tissue repair, not all tissue repairs are the same.
yes, that's true.
What
I
do you
only
think of the Desarda technique? Have you heard of
um,
Desarda?
yes, of course.
So I was trained, I had a mentor, he was trained, I think in the 1950s,
Yeah.
when he did residency. And when I told him about Desarda, he said, oh yeah, we need to do something similar back. We stopped doing it. There were so many recurrences. But what do you think about Desarda?
I don't like it. I can't
Yeah.
tell you why. Because you take the external oblique
Mm-hmm.
to reinforce or to strengthen the posterior wall. You pull it down and fix it in the groin canal, you know.
Yeah.
You take the external oblique, which is a very important layer to close the as the upper layer of the groin canal. Why
Yes.
should you take it when you can take the posterior wall at the best fascia, the best structure to reinforce?
That's the most important layer. Yeah.
Yes. And also, if you pull it down, there is the ilioinguinal nerve, there is the iliohypogastric nerve, which can come, which can get under tension, you know. And if you think about all this, I wouldn't use the Desada technique.
Yeah, I
You know,
agree. And I think
yes,
history we can't repeat history, right? It's been done before
yes,
and no one remembers, but you know, if it was done back in the 50s and they stopped doing it, there's a reason for that.
yes. I think this is the reason which I do. Yes.
Well, thank you so much. That was a full hour. Everything went by so quickly. Can you believe it?
Unbelievable.
So,
No,
and we went through almost all the questions, so that was great.
great.
So if patients would like to contact you
Yes.
from out of country, how do you do that? Do you do like video? Do they have to come to see you? Is it by email?
Everything. We do it by email, we do it by video. I have an international office for all the patients from abroad. They handle all these questions with the possible date to see the patients and to answer all the mails or to organize a video conference, do everything.
Okay, good to know. And then when you decide to operate on patients, how does that work? So you do all the decision making before you see them probably,
Yes.
and then you go to their country.
So
You see them.
we make a so-called combine date. That means the patient comes for examination and ultrasound, and for to say the indication for surgery or not. Then the next day would be surgery. The day after, I see the patient again, and then they fly back. And we are always in contact until the suture has been removed, which they do by themselves. It's only a running suture, you know. And then we are in contact with mails or pictures, whatever is necessary.
Yeah, very good. Well, thank you very much. That was a fantastic hour. I really appreciate it. It's middle of my day and end of your evening, so I appreciate the time that you afforded us, and I hope that if you have any patients, you forward them to HerniaTalk, because we have lots of videos with specialists like yourself, and we have a full website, herniatalk.com, where patients just discuss everything about hernias. So thank you, Dr. Muschaweck. I appreciate your time. Hope you have a good evening.
So much. Thank you so much for inviting me. It was a big honor for me to do so.
I appreciate that. And thank you everyone for joining me. It was different, earlier hour than usual, but that's what we do for our European friends and colleagues. Join me next week. We'll have another episode of HerniaTalk live.
Yes.
And see you then. Thanks everyone.
See you then. Have a great day. Bye-bye.
Thank you. Bye-bye.
Good night.